So welcome, everyone. Thank you for joining us for the first session in the Canadian Breast Cancer Network's virtual series, Questions and Experts. I'm Jen Gordon, the Director of Operations with the Canadian Breast Cancer Network. And I'm so pleased that our first session in this series will focus on answering questions around HER2-positive breast cancer. Each of the Q&A sessions that we'll be hosting will feature an expert speaker who will spend the entire webinar answering your questions about a specific topic. Future sessions will include medical oncologists answering questions about HR-positive breast cancer and triple-negative breast cancer, a surgical oncologist, a drug access navigator, and a naturopathic doctor. You can subscribe to CBCN's e-newsletter. The link is provided in the chat box, and this will help notify you of future upcoming sessions. I would like to extend our sincere appreciation for our sponsors for this session, our gold level sponsor, Viatris, our silver level sponsor, Pfizer Oncology and Roche, and our bronze level sponsors, AstraZeneca, Knight Therapeutics, and Merck. And I would now like to welcome the host for this session, Kathy Amanda Lea, who is the chair of the board of the Canadian Breast Cancer Network. And as someone who has personally experienced a breast cancer diagnosis, Kathy understands the importance of having information to make critical treatment decisions. In her volunteer role as the board chair, Kathy works to ensure the lived experience of people with breast cancer informs decision makers and policies that impact patients. So Kathy, over to you.
Hi, welcome everybody. Thank you for all the participants attending. Thank you, Jen. It's a pleasure to host the first in this Questions and Experts series, and I'm looking forward to having this full session dedicated to answering your questions. Thank you very much, Dr. Gelmon, for answering these very important questions. Just so of note, questions can be submitted throughout the session using the Q&A icon at the bottom of your screen. So with regards to Dr. Gelmon, I'm honored to welcome Dr. Gelmon. She's a medical oncologist as our expert for today's session. Dr. Gelmon is a senior scientist and medical oncologist with the BC Cancer Agency in Vancouver. She was co-chair of the Breast Site Committee for the Canadian Cancer Trials Group and co-chair of the Scientific Advisory Board of the Ontario Institute of Cancer Research. She continues to do clinical research and is now chair of the University of British Columbia BC Cancer Research Ethics Board, as well as continuing to do clinical work. So I'd like to welcome Dr. Gelmon again. We have some questions that have been submitted in advance. So we will answer with a couple of these to start. We will start with a couple of these questions that were submitted to start the conversation, while additional questions are submitted through the Q&A. So I'd like to begin with the first one, which may be related to the impact that the COVID-19 pandemic has had on treatment schedules. So Dr. Gelmon, the first question submitted reads, some people are now getting their treatments every 4 weeks instead of 3. Is that something that is available to everyone? If not, what is the criteria to have this? So I'm not sure the angle of that, Dr. Gelmon, but I'll leave it to you to make that,
I'll try to answer that in the best way. So I think what people might be talking about is drugs like Herceptin or trastuzumab. We're talking about HER2-positive cancer, and we know that one of the mainstays of treatment for HER2-positive cancer is trastuzumab, also known as Herceptin, or pertuzumab, also known as Perjeta. In the adjuvant setting in early breast cancer, we tend to give those drugs every 3 weeks for a total of 17 or 18 times, so for a total of a year, and that's been shown to be effective. In the advanced setting, sometimes we do put it out to 4 weeks rather than 3 weeks, and that's based on a number of things. Drugs have what we call half-lives. That's how long they're in our bodies. So a half-life is the time it takes to go from the full dose in our body down to half the dose. And what we know with Herceptin, and we've known now for a number of years, is that half-life is quite long. Many, many years ago in the early 2000s, there was a first study done giving 3-weekly Herceptin, and it was done in Montreal, Vancouver, Ottawa, and Hamilton. So it was a Canadian contribution to science. And at that time, we measured the levels of the blood, of the Herceptin in the blood, and we found that we were able to give it every 3 weeks. Before that, it had been given weekly. Following that, a fellow of mine and I looked at giving it in a longer span and to see how long it took for the body to clear Herceptin below a level that we think it's active at. And we know that it takes about 12 weeks to get the level of Herceptin up to the adequate level in your body. But then it takes 16 or 18 weeks for it to come down to be at a level that's not safe. That taught us that probably it's safe to give it every 4 weeks. In the advanced setting, when I'm treating someone, even before COVID, with metastatic advanced breast cancer, HER2-positive, after the first 3 to 6 months when I know that that person is responding, I often make the Herceptin or the Perjeta every 4 weeks because it's likely just as active because of how it's cleared from the body, and it's way easier for patients. Coming once every 4 weeks makes a huge difference. I mean, it sounds crazy, but it's 3 times in the year. It's, it makes a difference or 4 times in the year, it makes a difference for people. Now, I know that other people were not keen to do this, but gradually over time, there's issues around resources. And one of those issues around resources have been COVID issues, including how often do you want to expose someone to a chemo room? How often do you want that person to come to the cancer center? Can we limit the number of visits and protect them from COVID somewhat? So knowing that the pharmacokinetics are safe, knowing that it's safe, I think a lot of oncologists are now considering having their patients come every 4 weeks. I have some patients who refuse, who say, I'm sorry, the package label says 3 weeks. And I think it's the right of everyone to say that. But I have a lot of patients who say it's so much easier for them to come every 4 weeks. If they're getting something like pamidronate for their bones, or if they're getting gaserelin for their hormones, or if they're getting another drug, those are often every 4 weeks, and they can coordinate it better.
Yeah, well, that's great. So I'm assuming that this pandemic has also shown a different way of treating patients. Am I to assume that maybe strategies will change, or has this been always the case in terms of always 3 weeks versus 4? Has that steered it in different ways, having had the pandemic?
So I think the pandemic's done a few things. In some jurisdictions, there's been less screening, which is a problem, and that's a problem. In some places, people have been scared to go for their mammograms and ultrasounds, and that's a problem. Most of the hospital and clinic facilities are safe, and people shouldn't be scared. But what has happened is a lot of people are now getting televisits rather than face-to-face visits. And I don't believe that all medicine can be done by televisits, but maybe for some people, every other visit can be done by a televisit, and some visits can be done face-to-face. So I think the major thing that's happening in Canada with the pandemic has been more telemedicine, more Zoom or telephone visits. And as I say, some people like it, some people don't. I must admit, I far prefer seeing somebody face to face, but I also want to keep patients safe. So if we can limit the amount of time they have to come to a clinic, if we can decrease the number of visits, that makes a difference. I think in terms of trying to deliver care, there's this balance. There's a balance between trying to give the best cancer care. We don't want to let up on giving the best cancer care, plus keeping people safe. And I think that is a real important balance that we need to get to. The other thing that I think is a balance is around resources. I live in BC, and thus far we've been lucky. We haven't had resources in terms of our nurses or our pharmacists or our doctors being problem. But in some places, there have been resource issues and there are fewer healthcare providers. And in that situation, sometimes it's just been difficult to deliver care. So I think what we're always trying to do is deliver the best and the safest care we can to our cancer patients. But there are going to be situations. To go back to the 4 week, we think it's safe. So that isn't something where we think we're compromising care. Certainly, I wouldn't give an early breast cancer, or I wouldn't give at the beginning of treatment until the levels get up. But I think later on, it still is giving good care and it's safe. So it's this balance of safety and care. And I just want to remind everyone, get your vaccinations, but still wear your masks. We can't let up our guard, but get your vaccinations.
Excellent, excellent. I think that's pretty clear. Thank you, thank you.
Just to
So,
interject, Kathy, because we do have one question coming in from the live audience that actually speaks to that time frame as well. So just to sort of add on to your last question, and you mentioned Perjeta, Dr. Gelmon, and Herceptin. What about Kadcyla?
TDM1. So TDM1, I just see that question, and thank you, Carrie, for that question. We don't have as much data on TDM1 yet, or Kadcyla. There was a trial done a number of years ago, Amelia, where Sunil Verma, who was at Sunnybrook, was the first author on the paper there. And it was one of the first trials looking at TDM1 versus lapatinib and capecitabine. That trial had a paper published that was in a sort of journal that nobody read. And what it showed was when the dose of Kadcyla or TDM1 was decreased too much, so it's usually 3.6, down to 3 was fine. But when it went below 3, there was a suggestion that the people did less well. So a lot of us are a little bit worried about decreasing dose too much. What about decreasing frequency? There's not a lot of data for that. I have, during this pandemic, some people who have been worried about coming in, I have put it over to 4 weeks, but I've maintained the dose of 3.6 milligram per kilogram or 3 milligram per kilogram. And I think it's one of those places where I have to be honest with you. I don't think we have the data. So I feel more comfortable with pertuzumab and trastuzumab because we have more data. I have less comfort with TDM1, but again, every person's an individual and there might be situations where it might be fine.
that's great. That's fantastic. I guess we're all learning with the pandemic, and everybody seems to be adjusting, and there's going to be hybrids on everything that we do from this point on. So we kind of got like into that mode where this is had us think outside the box in some cases. Thank you, Dr. Gelmon. So perhaps this question is also, and within the parameters of the pandemic, in mind, the question, and I'm curious about this myself, is there is talk of a future vaccine to prevent the cancer from growing. Are you able to comment or provide insights into any of this research?
So vaccines are on everyone's lips now, but HER2 vaccines have been in development for a number of years, about a decade. The first few HER2 vaccines weren't very effective, but there have been some that have been developed, and there's been some big trials looking at giving vaccines to persons who are at high risk of relapse to see if you can decrease relapse. There have been vaccines given for other non-HER2 breast cancers as well that haven't been effective. What's interesting now is the mRNA technology, which we all hear about with the Moderna and the Pfizer vaccines. That technology was being developed not just for infectious diseases, but for cancer. And one of my colleagues, who's a very wise oncologist, was on a Moderna advisory board for years talking about how to introduce those into cancer. There hasn't been an advisory board meeting since the pandemic started, though, because they got sidetracked into COVID. But that technology, I think, and many of us think, is going to be very exciting in terms of how to deliver vaccines. Now, when will vaccines be used? First of all, HER2 might be the area of breast cancer that's going to be most easy to target because there's a target you can give, and it's an important target. So HER2 might be the first place where these kinds of vaccines come in. I don't think vaccines are going to replace chemo, but are vaccines going to allow us to further decrease the risk of recurrence in early breast cancer or in high-risk breast cancer? Or are vaccines going to be effective in controlling advanced disease? And I think right now it's everyone's guess. I think we're going to need to do the trials. I don't think anyone can give up on their treatment right now for a vaccine. But my guess is that, within the next few years, we're going to have those trials up and running. and maybe within 5 or 6 years, we'll have some results from them, but it's going to take a while to figure it out. But the technology, the same platform, that same mRNA platform that's being used for the Pfizer and Moderna vaccines right now is going to have a lot of value in not just breast cancer, but other cancers.
Yes, yes. And I do remember reading proposals with that mRNA, and when I saw it coming up with the Pfizer vaccine and the Moderna, I thought, wow, we've been doing this, I've been reading about this for years now. One quickie from me is I'm wondering if everybody's rushing to that now again, instead of leaving it just like, a little bit more on the background, like our researchers, pharmas, is everybody going to do a little more work around that type of work that I've not seen mentioned in the most recent years because of the vaccine?
I think there is. I think, we've been moving towards precision medicine for a while. We've been moving towards targeted medicine for a while. The big area right now in cancer treatment is a lot of the immunotherapies. The other big area is a lot of the conjugates. There's a new conjugate for HER2 called TDXD that people are excited about. So I think people are moving in that area. But I think in terms of precision medicine, if we can use the mRNA or similar platforms to target particularly aspects of cancer like HER2, I think that's going to be an area where a lot of people are going to go. I think what we want to be is barking up lots of trees. I don't think we want to be focused on just one tree. We need to be barking up lots of trees.
Very good. Thank you. Jen, I think I'll hand it over to you. You must have had some questions coming in.
We do.
Okay, go ahead.
Yeah, one of the ones that have come in, and it's around, are there other types of cancers that HER2-positive breast cancer survivors are more likely to get in the future? How do we test for those? Are there symptoms that patients should be watching for?
So I think there's one thing that's really important we get straight right now, and it's important, is that we have different kinds of genes. One kind of genes are what we call germline genes. Those are genes you inherit from your mother or your father, and they make up your DNA. People with certain germline mutations are at a higher risk of getting other cancers. So the one we talk about most is BRCA1 or BRCA2, and we know that persons who get those have a higher risk of getting cancers, higher risk of breast cancer young, high risk of ovarian cancer, in some situations pancreatic cancer, not for a lot of our women, but for our men with breast cancer, prostate cancer. There's a lot of cancers, melanoma, sarcomas are associated with that. There are a number of other germline mutations that are getting recognized. PALB2, CHEK, ATM, all of those germline mutations that are associated with cancer risk may put persons at a higher risk of getting another cancer. The other kinds of mutations are somatic mutations. And what somatic is body, and that is the tumor mutations. And within a tumor, there's either mutations or characteristics that are around that tumor. Those characteristics of the tumor are inherent to the tumor and are not necessarily associated with getting other cancers. So somebody with a HER2 overexpressing cancer has a breast cancer that overexpresses HER2. If they don't have a germline mutation from their mother or father, and most HER2 cancers don't, there's a tiny, tiny number that do, but most HER2 cancer patients don't, they're not at risk of getting other cancers. They are at risk of that cancer coming back. So unless you've got an extremely tiny, tiny cancer, there's always some risk of that cancer coming back. Why? Because cancers are made up of millions and millions of cells, and those cells can travel from one place to another. So even before that cancer is removed, there's a risk of those cancer cells traveling. That is the biggest risk with a cancer, is it coming back in brain, bones, liver, lung, anywhere. And that's not a new cancer. So someone who's had a HER2-positive breast cancer who then relapses in their brain, it's not that they now have brain cancer. They've got breast cancer metastasized or relapsed to the brain. So I just want to get that straight, that there's two different things. And as I said, although there are some persons with BRCA who get HER2 positive cancers, it's a tiny, tiny minority. And so most people with HER2 positive cancers don't have a very big risk of getting another cancer. I hope that answers the question.
I think that's very clear. Yes, thank you.
Jen, would you like me to read one of the questions that was submitted?
Yeah, Kathy, we'll go back to you.
Great. So the next question is the following. What are the best treatment plans for high-risk HER2 positive breast cancer? And are CDK4/6 inhibitors plus anti-hormonal drugs something that should or could be used for non-metastatic cases to reduce risk of recurrence? That's a mouthful.
That's a mouthful. So first of all, there are a number of different treatments out there for high-risk HER2 positive breast cancers. Increasingly, we do chemo before surgery, something called neoadjuvant chemo. And we often give Herceptin, trastuzumab, pertuzumab, which has just been approved in Canada and hopefully will be funded soon, plus chemo. We give that to the person up front. We give it for whatever 6 or 8 cycles, sometimes 4, 6, 8 cycles of chemo, and then we do surgery. If there's no cancer left at the time of surgery, then we continue on with the Herceptin after for the full year. If there is cancer left, then the recommendation now would be to get TDM1 or Kadzilla after the surgery if there's residual disease, if someone tolerates it. Not everyone tolerates it, and some people have to go back to Herceptin. And that's still the best treatment. If there's a big tumor or nodes involved, then radiation is included. If it's hormone positive, then hormone therapy is given, usually after the radiation, while the person's still getting either their TDM1 or their Herceptin. The interesting thing about the CDK4/6 inhibitors is that there have been some studies in advanced breast cancer giving CDK4/6 plus hormones plus Herceptin and showing a benefit in the advanced setting. There's been no data yet in the early setting for adding in CDK4/6 inhibitors to HER2 positive breast cancer. So even for a high-risk HER2 positive breast cancer, there's no data yet to add in CDK4/6 inhibitors. That doesn't mean there won't be data in the future, but there isn't anything now. And we're always loath to add in things until we really understand if they're going to be a benefit or if they're just going to add toxicity. We don't want to just add toxicity. So adding in more isn't always the right thing to do. Mm-hmm. What I do have to say, and there was a question early on, was talking about relapse rates. The majority of HER2 positive breast cancers treated either in stage 1, 2, or 3 are going to be cured of their disease in Canada in 2021. Not all of them, there are still some that relapse, but HER2 positive breast cancers have been one of the places where we've made the most inroads and where we have some of the lowest relapse rates. So even a stage 3 HER2 positive has a very good chance of getting into a very good remission with the right treatment. So the relapse rates have gone way down. Now there's always room for improvement, and that's where things like giving Kadzilla or TDM1 after the neoadjuvant treatment has come in. There'll be other areas of improvement, but right now I have to say that, you know, it's one of the areas when somebody has a HER2 positive breast cancer, I think often, oh good, if it's a stage 3, because their chances of doing well are better than somebody with a non-HER2.
Thank you.
Not CDK, maybe in the future, but not yet.
Okay, just a very quick follow-up to that. Do you, not you yourself, but is there a decision-making around these treatments with in mind the age of the patient?
That's a good question, and there have been a lot of studies. First of all, there is data to suggest that stage for stage, a lot of young women have a more aggressive cancer. Even though it might look the same as another cancer, a lot of young women have a bit more of an aggressive cancer. Sometimes that might be related to the fact that they might have what we call a germline mutation, and that might make it a more aggressive cancer, but there could be other reasons. We know that 50% of young women, women under 40, still have ER-positive cancers, so they're not all triple-negative cancers. We know that women under 40 have a higher rate of HER2-positive cancers and triple-negative cancers. These are more aggressive. So a lot of people will treat younger persons slightly more aggressively. Having said that, a lot of the guidelines say just because someone's young, don't treat them more aggressively. So, it's something that we're learning. When we look at older women, there's been a lot of question about whether we're ageist and whether we don't give treatment to elderly women, which we should give. And I think what's interesting is the definition of elderly keeps changing. As we all get older, elderly keeps moving up. And I think that you have to look at the person. So I think if you've got someone who's in their 90s, chemotherapy is not going to make them more robust. Chemotherapy is going to have trouble. And you have to really talk about how much you're going to do. But I think for somebody in their 70s or early 80s, then if they're in good shape and they have the likelihood of living another 10 years without other health problems, I don't think we should be ageist and we should be treating those persons. So I think age comes in, but it's more around other comorbidities, other health problems, and patient preference. I've had some patients come in who just say, I don't want anything. I've had a good life. And I have other patients who come in, who are older, who really want treatment. I have some young patients who don't want treatment, and I have other young patients who want treatment. So I think it's important that we look at the whole person and make a decision based on that.
Yes, and I think that's the golden rule. You treat the patient for who the patient is. That's absolutely the best way. And nobody's the same. Not every patient is different. Jen, I'm going to ask you to ask some of the Q&A questions that are coming in right as we speak.
Absolutely. And actually just building on the high risk piece, and maybe Dr. Gelmon, you can speak a little bit more to assessing or how patients and their medical oncologists assess who's high risk. So this question is particularly from a patient who is stage 1B. Her medical oncologist says she's at low risk and she's done Taxol and 17 Herceptin, but she's looking at something like neratinib, so Nerlynx, and that sort of speaks to Kadcyla in the adjuvant setting as well, right? So how do you assess whether or not you're going to benefit, or how does the medical oncologist assess who's high risk and who might benefit from this additional therapy, and how do patients consider that in their treatment decision making?
So I think that first of all, what we said already is, we're not always right, but we try to do our best. One of the things with breast cancer is we have a lot of outcomes data. We have outcomes data from some of our local places, like BC has good outcomes, Ontario has outcomes data that we followed along. We also have outcomes data from SEER, from the US, from international. So we're able to look at a cancer and a cancer stage and be pretty good at being able to say this is low risk or high risk. I know a lot of people get scared and they want more, and they say, I don't want less, I want more because I want to do everything I can. But there's toxicity with doing things, and you don't want to do it just because you can do it. Just because you can get it doesn't mean that it's right to get it. If a cancer is very small, particularly less than 1 centimeter, then it's usually low risk. If the nodes are negative, it's usually low risk. For a cancer that's less than 5 millimeters, most of us don't even give chemo or Herceptin, even if it's HER2 positive, because the risk of relapse is so small, and yet the toxicity from the chemo and other drugs is higher. So when you do that balance, you're not doing somebody a favor. Every so often, there might be someone where it's 4 or 5 millimeters, and you will give it, but if it's 1 or 2 millimeters, you probably won't. Between 5 millimeters and 1 centimeter, we do give chemo. And between 1 centimeter and 2 centimeters, we definitely do give chemo. And between 5 millimeters and 1 millimeter and 1 centimeter, sometimes it depends on the person. Sometimes it depends on their other health problems, whether we do or not. But someone who's otherwise well, young, with a HER2 positive cancer, we usually would give treatment. There have been a lot of data looking at this. The initial studies with Herceptin, most of them didn't include the people less than 1 centimeter, but there have been some good studies, including one from Sarah Tallaney from Boston, looking at giving weekly weekly paclitaxel or Taxol with Herceptin, and the Herceptin continued for a year. In that study, she included people with tumors up to 3 centimeters, And most of us don't use up to 3 centimeters, but up to 2 centimeters nodes negative, particularly if it's ER positive, we would think that's more than adequate treatment. With a 7-year follow-up of that study, over 96% of people were still well without recurrence. So that meant that only about 4% had relapsed. So when you looked at those 4%, they were higher risk than a T1B. I would recommend to the person who submitted that question that she's had or he has had very good treatment. I would not give more treatment. I would not give neratinib. The study that we used for neratinib, and we did that study where we gave neratinib after the chemotherapy, would not have allowed in somebody with such a low risk cancer. What we want is persons with breast cancer to be cured and to live long and fruitful, healthy lives. If we give too much treatment, we suffer the risk of not having them live a healthy life because we've done too much damage. So the hardest thing for anyone with a diagnosis of cancer to do is to live with the uncertainty, to live with that uncertainty of is the cancer going to come back or not, and to feel satisfied that they've done enough. And that's what makes people vulnerable to eating kale every meal or to doing something else to try to keep the cancer away. And I think that's something that people have to get in themselves and do the spiritual work to live with that uncertainty. As adults, we're all living with uncertainty. That's one of the things of going from being a teen to an adult is learning how to live with that uncertainty and not having it overcome us, that we go out in the world each day and we aren't worried about getting run over by a bus or getting struck by lightning or the cancer coming back or us having a heart attack. You have to live each day and know that we're all living with that uncertainty. So I think for a T1B, I wouldn't recommend neratinib. I would recommend that she's had good treatment. I want to just take another question right now before we forget it is about the vaccine and tamoxifen. Tamoxifen, chemotherapy, Herceptin, aromatase inhibitors, letrozole, none of those interfere with getting the vaccine. Get the vaccine. Immunosuppression is a broad term. Most women with breast cancer on hormone therapy aren't severely immunosuppressed. Tamoxifen doesn't add to it. There's no interaction. Get the vaccine. So I just want to reemphasize that, and I see a question about that.
I think that's a very good point that we can make over and over again throughout the session and forever until we're all immunized. One little quick question for me is in terms of the year-long Herceptin regime, do you think there will ever, or is there any consideration of modifying it to have a lesser time with the same effectiveness of receiving the treatment?
So Kathy, that's a very good question. One of the studies we did looked at 1 year versus 2 year and showed no benefit for 2 years. There have been a number of studies looking at 6 months. There was a study from France that was closed early because the French government didn't want to pay for it anymore. And it didn't show that there was much difference. Maybe the 6 months was a little bit inferior. There was a big study from England looking at people, some people who got chemo and then Herceptin, some of them got it for 6 months, some of them a year. Some of them got it the way we tend to give it now with the chemo and Herceptin together, some people getting Herceptin for 6 months and some for a year. What the study from England showed, which is probably the best study out yet, and there are still some studies to come out, is that there was not a lot of difference, but there was a slight suggestion that those people who got chemo plus Herceptin and only got 6 months had a slightly inferior outcome. So it basically said that a year is standard. Now, having said that, although a year is standard, if at 15 cycles, I have someone who says, I can't do anymore, I think with the data from 6 months showing that it's not really very inferior, I would say, okay, stop. Or if someone gets heart problems at 15 cycles rather than 17 cycles, you can stop. Or if somebody suddenly has to go back to Brazil because their mother has COVID, you can stop. So I think that, it's given us some comfort in stopping early in patients who need it, but the standard is still a year. Now, there have been studies, and there's some studies now looking at for those patients who get chemo up front and get into a complete response, do we need to give the Herceptin for a year after that? And that is being looked at, but we don't have an answer yet.
Okay, just that it's been a year forever. So I was just wondering if there was any change
Well,
in
we've
the,
tried. So we tried to make it 6 months, but not successfully.
Okay, great. So we have a couple of questions that are around the use of Perjeta, but in the metastatic setting. So I'll go with the first one, and that would be, Perjeta is known to work on HER3 in addition to the HER2 pathway, and often brain mets are involved with HER3. Is there any evidence that Perjeta is crossing the BB after stereotactic radiosurgery to keep the brain stable from further brain mets? At what point is it safe to consider discontinuing Perjeta, in brackets, due to neuropathy side effects?
So that's a good question. So the blood-brain barrier is there so that when you drink your wine on Friday night, all of it doesn't go to your brain. But the blood-brain barrier is a membrane that isn't completely blocked. It's not a complete fence. And after someone's had surgery or radiation or other treatments to their brain, often the blood-brain barrier becomes more permeable, so more things get through. There is a suggestion that both Herceptin and Perjeta get through the blood-brain barrier to some degree. It's variable, though. The levels in the brain are not as much as they are outside of the brain. Generally, people believe that if the brain is the only place of progression and people are stable from the neck down on, let's say, their Perjeta and Herceptin, that they should continue the Perjeta and Herceptin indefinitely, regardless of the fact that the disease might have progressed in the brain. If the disease progresses in the brain and below in the rest of the body while someone's on Perjeta and Herceptin, then the usual thing would be to change the treatment to get the treatment, the rest of the disease under control with a new treatment. Sometimes people have to stop for toxicity. So toxicity is a different reason. So if someone's got brain mets, has had treatment, the rest of their body is controlled, but they're having toxicity, then they may want to talk to their oncologist about stopping for toxicity, but that's a different reason than for treatment. Perjeta, a lot of people complain about neuropathy with Perjeta, but the neuropathy is often a hangover from the previous taxanes. And the Perjeta might keep it happening, but it's usually not the main cause of the neuropathy. The neuropathy is more often caused by the previous chemo. So I think it's, again, what you were saying before, Kathy, every case is different.
Mhm.
And I think what people should realize is that if they stop the treatment for toxicity, that might be good in terms of their quality of life and decreasing toxicity. It might not. If they stop it for toxicity, though, and their cancer grows, they don't want to be out of options for other treatment. So I think that's important.
Okay, excellent, excellent. Jen, I'm going to give it to you and just read out some of the live questions that are coming in.
Yeah, so Melody's asking what other treatments you could recommend or are currently being used for metastatic HER2-positive breast cancer for third-line treatment or after TDM1.
So that's an excellent question. And after TDM1, well, first of all, in Canada, where there's something big we have to change, someone along the way decided that people were only eligible for 2 treatments except in Quebec. And that's wrong. There's been lots of data to suggest that continuing with anti-HER2 treatment is important. And that's something that a lot of oncologists around the country are trying to change. There have been 2 drugs coming along recently that are new drugs that are very interesting for third line. One of the drugs is a drug called tucatinib, which is an oral drug, and it's given in combination with capecitabine, which is an oral drug and oral chemo, and Herceptin. And in a large phase 3 trial, it was shown that tucatinib, capecitabine, and Herceptin were associated with a better survival. Tucatinib is available a little bit right now on compassionate release from their company, and people have to get the capecitabine and the Herceptin covered, but tucatinib is in front of Health Canada and in front of PCODER. It's been approved by Health Canada in front of PCODER, and we're hoping it's going to be approved across the country soon. The other drug is TDXD, which is a new conjugate. It's like TDM1, but it's different. It's got a different chemo associated with it. It's got a different linker, but it's got Herceptin there. TDXD is a very exciting drug, and it looks like it's going to be active in third and maybe fourth line. It's right now at Health Canada. It didn't have a phase 3 trial. It only had a phase 2, but there are phase 3 trials ongoing right now. And hopefully it'll be funded in Canada soon as well. Across the country, there are a number of studies going on using TDXD and using tucatinib. And so the other thing that people have an option for often is enrolling in one of those studies. As well as the new drugs, there are some old drugs. So there's still lopatinib and capecitabine around. There's trastuzumab and capecitabine. There's vinorelbine and capecitabine. Or sometimes there's old chemotherapies like doxorubicin that can be effective for third line. So there's a lot of things out there for third line. A number of them aren't yet funded across Canada, but they're coming.
I have a very quick, big question, but small answers, seeing that we don't have a lot of time. You touched on phase 1, phase 2, and how, quickly it can progress. Because of the way the pandemic accelerated the use of the vaccine, and I know cancer treatments are not the same as a vaccine treatment for COVID, let's say, or viral infection. Do you think that these will become more accelerated, these phases, these studies? Is there any consideration by anyone?
So often they are more. So TDXD is licensed in the US after only a phase 2. So that's more accelerated. Phase 3s are going on now. The vaccines were only approved after phase 3. There were large phase 3 trials to approve them. So there were phase 1, 2, and 3 studies with the vaccines. What we always have to remember is, although we want progress, we want safety. So we have to take both into consideration. So to answer your question, sometimes they are accelerated like TDXD, but sometimes the vaccine did take phase 3 trials for safety.
I wanted it as a point of clarification because I often get this from patients who I know, and they say, well, if they did that for the vaccine, how come we can't do that for everything else, especially in oncology for treatments? But that's a very good point, so that people understand that there was an actual phase 3 done for the vaccine, and it wasn't skip 2 and then let's just move on. So I just wanted as a point of clarification coming out of you.
And there were phase 3s for all of the vaccines. So it's not just Pfizer,
Correct.
or not just Moderna, or not just AstraZeneca. There were phase 3s for all of them.
Okay, great. So Jen, are you going to take on, or do I continue with my submitted questions at this point?
Yeah, I think number 8, Dr. Gelmon already answered question number 7 that you have.
Right.
Number
so
8,
I'll go to number 8, because you're right, she already answered that one. So could you explain PARP inhibitors and why/when a PARP inhibitor agent would be used?
So PARP inhibitors are for those, we talked about germline mutations. Germline mutations are those mutations that you inherit from your mother or father. Some cancers, only about 5% of breast cancers are in people with germline mutations. For triple negative cancers, a woman who's 35 with a triple negative, it might be up in the range of 35%. A woman who's 60 with a triple negative, it'll be less than 10%. So germline mutations don't account for a lot. Some cancers can be ER positive or ER negative. And as I said, it's only a tiny number of HER2 positive cancers that are from germline mutations. Thus far, PARP inhibitors have only shown efficacy in those persons who have a cancer that's got a germline mutation, mainly with BRCA1 or 2. There's some preliminary evidence for with PALB2. There's not a lot of evidence yet for ATM or other mutations. There are studies that we're starting looking at triple negative cancers who have what's called HRD, or homologous recombination defects, and to see if those are going to be affected by PARP, but we don't have that data yet. So if we're talking about HER2 positive cancers, the treatment is anti-HER2 therapy, and PARP inhibitors really don't have any place yet. But they do have a place in those tiny minority of women who do have BRCA mutations and advanced disease. And we're going to hear data at the ASCO meeting in June about using PARP inhibitors in earlier breast cancer for those patients who have BRCA mutations. So it's a tiny little segment of the breast cancer population.
Thank you. Thank you. I'm going to go on to my next question that has been submitted. Can Herceptin or some variant thereof be used as a prophylactic? Often people will ask that about all kinds of drugs and say, can we use these as prophylactic and then
So I
be
think,
done?
I think prophylactic, you're meaning prevention. And I think as prevention, there's been no evidence. First of all, remember only about 15% of breast cancers are HER2 positive. So you're only, even if it was effective, it's only about 15% of breast cancers. Remember, Herceptin has side effects, and there's a question about heart toxicity. And so Herceptin does potentially have heart toxicity. So no, Herceptin is not going to be used as a prevention because it would only prevent a minority and because it's got toxicity. How are we going to prevent breast cancer? You know, we've done lots of prevention studies. The majority of breast cancers are estrogen positive, and most of the prevention studies have looked at giving hormone agents to prevent breast cancer in high-risk persons. There's people looking at other things, and I think environmental and lifestyle things may have some impact. But right now, the Herceptin or those things shouldn't be used for prevention.
Touching on that, environmental and lifestyle, do you think that we're continuing to do good work in that? Do you think there's any success in that?
I think we're continuing to do good work, and I think there's two sides to it. First of all, one of the most damaging things I see is persons beating themselves up for getting cancer. And, you know, I have my glass of red wine like the rest of others. And, you know, so many people come in and say, it was the wine I drank, or it was the stress at work, or it was I didn't exercise enough, or I didn't eat the right diet. And nobody should beat themselves up. We don't have one lifestyle intervention right now that's going to prevent cancer. Working in downtown Vancouver, I have a lot of vegans who are healthy and who exercise who get breast cancer. So lifestyle alone doesn't prevent. I think what we are learning about more and more is some of the chemicals that are around. And I think that's where we have to be concentrating, and there's work in that. There was just an article yesterday about Parkinson's and some chemicals that are in various different household things. So I think learning more about chemicals is important. I think food additives, you know, the Michael Cullen stuff about, you know, if there's more than 5 things in a food, don't eat it, you know, don't eat food with too many additives. And I think more and more we're making our own foods and not using a lot of additives. So I think cutting down on those things. I think balance is important. Balance in terms of diet. You don't necessarily have to be a vegan, but getting your protein from lots of different sources. Balance in terms of exercise. Getting enough sleep is important. There are some people who say, no, we shouldn't have any alcohol. I'm not one of those, but I think we have to all look at how much alcohol we drink. So I think there's balance. And right now, there's no one lifestyle maneuver that's going to prevent all breast cancers.
Yes, especially
and don't
when
beat yourself up.
Yeah, especially when there's a genetic, you know, component to a lot of how we are made. You can't beat ourselves up for being who we are and how our genes have developed us into getting or not getting various
Exactly.
diseases.
And one of the things that's come out that's been interesting, that's come out for the last 20 years, but with increasing evidence is, you know, you can start smoking at age 50 with no risk of breast cancer. But if you smoke within 5 years of getting your periods, and not just the odd puff, but, you know, serious smoking, or if you've had more than 10 years exposure to secondhand smoke before your first pregnancy, you're at a higher risk. So, you know, I have women who come in who lived with a mother who smoked at home. You know, that doesn't happen very much anymore. They can't change that. Their mother smoked. You know, you can't go back to your childhood. But what we can do is us not smoke and make sure our daughters don't smoke. So, you know, I think going forward.
We put the foundation for the next generations to come along. Exactly. I'm going to go on to the next question. Jen, did you want to project?
Yeah, there's one for a question coming in from Lynn. And actually, while we're speaking of the genetic risk in that piece, and her question is around the fact that she was diagnosed in her early 40s with triple positive breast cancer. And she has 2 young daughters, both who've had various breast lumps removed and have been getting them removed due to growth. Are there any particular tests that they should be having done with these removals? And perhaps at the same time, Dr. Gelmon, you could address some of that familial risk and what we can do with that and what can be done for women's daughters who may be at an increased risk.
So I think one of the things is people talk about daughters, and a lot of that was before we understood genetics, and we still don't understand genetics completely. In the early 90s, Marie Claire King, who just won the Gardner Award, described BRCA1. We looked at 2 genes for a long time. Now, if you get tested by Invitae, one of the commercial groups, it's 84 genes. And 2 years from now, it might be 284 genes. So we're learning more and more about genes, but as we learn about those genes, it's going to be easier to determine which daughters are at risk and which aren't. As I said, HER2-positive cancers, although they occasionally are associated with germline risks, it's not very common. I'm hoping soon in Canada, we look at each tumor and we look for these genes, but we don't do that yet because we know family history alone or diagnosis alone is not enough. So if somebody's having lumps and they're just benign lumps, all of those lumps should go to pathology. So anyone who's getting a lump out of their breast, it should get full pathological diagnosis. You know, the old days where a doctor just took out a lump and threw it in the garbage shouldn't be happening. It all should go to pathology. So people should know what it is. If it's a plain fibroadenoma, there's no evidence that benign fibroadenomas turn into cancer. If it's something called dysplastic, which has some abnormals, then those things can be worrisome, or something called atypical lobular hyperplasia or ductal hyperplasia can be a worry. So it matters what those lumps are, but they should know what those lumps are. And the surgeon who's removing those lumps is going to be able to tell them, is this a lump that's worrisome for developing cancer or not? I think one of the things is that our genetics programs have to expand, not to make people more fearful, but to make people less fearful so they know, do they have the genetic risk that we're aware of now. And with a lot of my patients now who have worries, even if they don't have the full familial risk, some of them I'm doing private testing that they're paying for. It costs a couple $100, and they're getting private testing to make sure they don't have one of the 84 genes that we now test for. That doesn't mean they don't have the 284 genes we might test for in 5 years, but they don't have the 84 genes. And that's likely going to cover most of the genes. So I think that if somebody is worried about their daughters, talking to their oncologist about whether they should get further testing for genetics is important. Age 40 and a HER2 positive, the risk of having a genetic mutation is not very high unless there were multiple other cases of breast cancer happening in people under 50, or unless there's ovarian cancer or pancreatic cancer in the family as well. So just one person with a HER2 positive cancer at age 40 is unlikely to have a high chance of having a germline mutation.
I just want to go back to something you said. I thought they send everything to pathology at the hospital. Even if they cut your nails, I think they send them to pathology, right?
Yeah, they do now. They do now, and they should.
And that's the joke that I always say. I think they'll send it to pathology. Even your nail gets clipped.
Even your nails,
it's going to pathology.
Yeah.
So
but your pedicurist might not.
No, not the pedicurist. I'm saying in a hospital setting. I'm going to go on to the next question. This is fabulous. I'm having a good time with these questions and your answers. Is there a relationship between it? Is there a relationship between inflammation in the body? That's always a question. And cancer, and can drugs such as rapamycin, I don't pronounce that properly.
Rapamycin,
and metformin be used as cancer preventative? I think these questions have been asked before. This is something you may have answered, right, over time?
Well, not quite, but slightly different. So there is a lot of work going on looking at a number of different factors that might put you at risk of breast cancer or of cancer. Inflammation is one thing that's being looked at. But again, just like we talked about the immune system being really big, there's lots of different kinds of inflammation. And a lot of inflammation is not associated with cancer. A lot of people are looking at metabolic syndrome, people who have overweight or have insulin resistance or have abnormal sugars. Does that put you at higher risk of inflammation? Does that put you at higher risk of cancer. There's a lot of work that's gone on looking at metformin, and a lot of that work has been done in Canada by Dr. Pam Goodwin in Toronto, by Dr. Michael Pollock in Montreal, and by a number of other people who've looked at metformin and who've looked at insulin pathways. There's a large study called MA32 that was done by the CCTG with Pam Goodwin as the principal investigator, looking at whether metformin given to women who had a diagnosis of breast cancer could decrease the risk of the cancer coming back. And that study has not yet reported after years and years and years of follow-up. At this point of time, there's no good evidence of any drug such as metformin or rapamycin decreasing the chance of the cancer coming back or being used as a prevention. We're all waiting for the MA32 study to come out, and we're hoping that it does show something, but I don't know that it'll show anything after this many years. So we're still at the drawing board. It's a little bit like lifestyle. There's lots of good ideas out there, but how we affect them, how we change them, how we prevent breast cancer isn't clear yet. At this point of time, there are a lot of naturopaths giving metformin to decrease cancer, and there isn't the data for it yet.
I have a quick question. In your clinical setting, do you see any correlation with diabetes and higher risk of women coming in with breast cancer? Is that anywhere near that, like, maybe?
So, as I said, Dr. Goodwin's one of the leading experts in this, and Dr. Goodwin has done some old studies where she looked at insulin levels and women with higher insulin levels, suggesting an insulin resistance, suggesting their insulin wasn't working properly, suggesting what's called metabolic syndromes, that they had a higher risk of getting breast cancer. And that was one of her theories of why giving metformin, which would bring down insulin in women who weren't diabetics, might mean that there would be less risk of cancer coming back. So that was the whole theory behind it. It doesn't look like there's a real link with diabetes and that, but a lot of women who have diabetes are already on drugs like metformin, so that might suggest that they do something, but we don't know that yet.
Right.
There are other things that a lot of women talk about as well. What about people with kidney transplants or lupus or arthritis or other diseases or thyroid disease? A lot of the diseases that are immune diseases out there, which affect women often, and there's not good evidence about those causing an increased chance of breast cancer. One thing that always is out there, though, is obesity. And certainly in postmenopausal women who are overweight, there is a suggestion of a higher risk of breast cancer, which we think is probably either due to higher circulating hormones, including estrogen and testosterone and that, or issues around inflammation and insulin. So weight is one thing. And just to go back to lifestyle again, weight is a totally separate thing than diet and then exercise. All three of them, although we might think of them interlinked, they're all important on their own. So exercise is important on their own, and unless you're an extreme sport person, you're not going to lose weight with exercise, but you're going to tone, and it's going to be good for you. Diet is important, and again, there's no one diet. A broad Canada Food Guide diet, limiting the amount of alcohol, limiting the amount of red meat, limiting the amount of refined flours and sugars is important. But, no, it doesn't have to be strict every day. And weight is another thing. So having a normal weight is important. Now, that doesn't mean if you go up a few kilos here and there, it's a big deal. But all in all, having a normal weight is important. 3 different pillars that are all important in terms of prevention of not just breast cancer, but colon cancers, uterus cancers, other cancers.
I have a quick question in terms of the weight. Is that something that yourself and oncologist address?
I talk about it with my patients.
Okay.
It's not the easiest thing.
No.
Most women, coming into their oncologist, they're already talking about their cancer. Do they want their oncologist to talk about their weight as well? But I do talk about it with people, and I do talk about, what's been successful for a lot of my patients. A lot of my patients have found Weight Watchers online successful, or apps that like loseweight.com or one of those apps. The other thing that a lot of people are now doing is intermittent fasting or timed eating. And there's some suggestion, but it's not clear yet that, timed eating, having long periods where you don't eat, is good for your both insulin access, for your hormonal access, and for your weight. Decreases diabetes, decreases cholesterol, maybe decreases dementia. There are some studies that are going on in cancer looking at that, including in breast cancer. And again, I'm going to say what I've said before. We don't have the data yet, so don't rush out and all do it yet. But I think it's another interesting thing that might teach us more about cancer prevention, and cancer prevention in terms of recurrence, in terms of diet and how we eat.
Yeah.
Those
And
late night snacks.
Yeah. But I think like we said before, everybody's individual, whatever works for you. If it's that time, don't eat after certain time, or whatever diet works for you. I always say to people that I work with, patients that I meet up, just do whatever works for you, as long as it's safe and you've discussed it with your physician, your oncologist, whomever you see.
And as long as it's realistic. I mean, I see a lot of women in their 50s who think their ideal weight is what they were when they were 21. That's not their ideal weight. But when we keep weights in our clinics and we see over a few year period women going up lots of kilos, it's not usually just due to the tamoxifen or due to the letrozole or due to that. It's often due to, feeding ourselves to make ourselves feel better. And that's something that we all need to watch.
Very good. Jen, would you like to ask some live questions right now?
Absolutely, yes. So we have one around Oncotype DX diagnostic testing. Who is being tested? What setting is this test funded for patients? And how much is this guiding treatment decisions?
So Oncotype DX is a very good question. Just to tell people who aren't aware of it, the Oncotype DX is a commercial test. It's only done in one lab in California. It tests 21 different genes, and it tries to test those genes to get an idea about how aggressive is this cancer. The main role of the Oncotype DX testing is to give a recurrence score, and the first use of that is for persons who are estrogen receptor positive, HER2 negative, so not HER2 positive, who have cancers, and initially just cancers that were not in lymph nodes. What the first studies suggested was that this test could help determine who would benefit from the addition of chemotherapy to their hormone therapy and who just needed hormone therapy. That test, the Oncotype DX recurrence score, has been funded across Canada for node negative patients who have an adequate risk. So a tiny tumor that's 5 millimeters, you're not going to do, but a 2.5 centimeter tumor you would do. Somebody who's 95 and never going to take chemo, you wouldn't do, but someone who's 45 and would be a candidate for chemo, you would do. And that's been funded. More recently, in December, we got data showing that for persons who had 1 to 3 lymph nodes involved, the same test could be of value. And that was from a study that we participated in across Canada. And we had Canadian principal investigators from Hamilton and Vancouver, and participation right across Canada. So that was an interesting study we participated in. It's just rolling out now in the provinces of whether persons with 1 to 3 lymph nodes will get funding for the Oncotype DX, and that's another group. The only question it answers is whether there's a benefit in adding chemo to the hormone treatment. So we still prescribe surgery, we still prescribe radiation, we still prescribe hormone therapy, but the question is, do we add in the chemo? It's only for persons where adding in the chemo makes sense, who are going to accept chemo and who are going to tolerate chemo. And it's only in the situations where they're hormone positive and, as I said, HER2 negative. With HER2 positive cancers, we know they're more aggressive, and we know that there's a benefit for chemo and Herceptin and pertuzumab, so those cancers aren't candidates for Oncotype DX. It's not perfect either. We have patients where they're on a cusp, so they're on a border, and we have to look at that patient and say, okay, is it going to be a benefit or not? And we also know that the studies suggest that women under 50 have a different level than women over 50. So the level has to be much higher for women over 50 to have a benefit from chemo compared to women under 50. If you've got a 51-year-old with a, result that's right on the border, we're going to have a conversation and figure out what's best for that woman. But if we have a 51-year-old who's very low, we might say, oh, good, you've been spared chemo. Versus if it's very high, we might say, well, sorry, but we really have to recommend chemo. Ultimately, it's the woman's decision because it's based on her perception of risk and her perception of chemo and what the oncologist has told her.
Along that line about the cusp, I call it the gray zone. And some patients come to me and say, well, my doctor said it's in the gray zone. Is there ever a thought about having a different test done on these patients?
So that's a good question. So there are some other tests you can do, and sometimes you put together a whole constellation of things. So you might put a constellation of, well, it's on the gray zone, but it's very, very sensitive to estrogen, progesterone. Therefore, the effect of hormones is going to be very good. Or it's on the gray zone, but the progesterone is negative. Therefore, the effect of hormone might be less good. So you're going to look at those kinds of tests. I have one woman right now who had a cancer many, many years ago when she lived in Europe. It's recurred on her chest, or it's a new cancer on her chest wall. She's on a cusp. She's over 50. She's already had a cancer. She wants to do everything she wants to do. So her decision is to get chemo because she says, I don't need another test. I don't want to go through this again. I'm going to take chemo. So then it becomes a patient decision. And sometimes, it's really around what's the least regret. Is it getting chemo or not getting chemo and that. So there's not another genetic test that's really good right now, but there can be other tests that work. There's another test called Prosigna, and it really gives the same data. So it's not really as much of, it doesn't really change things. And just to go back to that T1B tumor, this is another way we understand cancers. We have long-term data with Oncotype of persons who have very low-risk cancer, where they have nodes negative, low-risk cancer, low score, and we've got an over 95% chance that they're going to be fine at 10 years. So that's another place we can reassure patients and give them that kind of long-term outcomes data. The good thing in cancer is we work internationally. So we're able to give these kinds of statistics to people to hopefully make them feel more safe.
And again, it's individual, right? Not one shoe fits everybody. So, yeah. Jen, would you like to do more live questions before I go on to my next submitted question? Do you have any live?
We do have several. I will try to get to all of them, but I think we'll have to combine a few of them. So Kathy, you can go ahead with one that was submitted earlier, and then it ties in nicely with one of the live ones as well.
Okay, good. So I'll go to my next and last submitted question, which is, if someone is diagnosed with early stage breast cancer, what is the likelihood that it will appear in the other breast within 5 years? Not sure what the 5 years means here. Does the stage of breast cancer make a difference in recurrence?
So there's a whole bunch of things all packed in there.
Yeah.
First of all, the stage does make a difference. And that's what we were talking about, why the stage 1B, a tiny little cancer of 6 millimeters that's node negative, has a different prognosis than, let's say, a 7 centimeter tumor with 10 nodes positive. So stage does make a difference. There's two aspects to looking at risk of recurrence. One is the biology of the cancer. What's the grade? How fast is it growing? Is it sensitive to estrogens? Does it have HER2? That's one aspect of it, the biology. And the other aspect is what I call the architecture. What's the size of the tumor? Is it involving the nodes? And that gives you the stage. So there's the biology and the stage. And we put the two together to try to come out with what's the risk of recurrence. A very low-grade estrogen positive stage 1 cancer is going to have a much less risk of recurrence than a stage 3 triple negative cancer. And it's all put together like that. So stage makes a difference. When somebody gets a cancer, we try to do our best at estimating stage, but we can't always do it perfectly. There are some cancers that appear to be lower stage and maybe aren't. And that might have to do with the kind of surgery. So For example, if only one lymph node was removed, we might know less about the armpit than if 4 sentinel lymph nodes were removed. So, sometimes there's variabilities like that. The biggest risk for someone who's had cancer is not getting cancer in the other breast or getting a new cancer, but getting the cancer they had back, because we know they already had that cancer. And the reason that cancer comes back is, as we talked about, cancers are made up of millions and millions of cells, and those cells can travel at any time. Unfortunately, they can travel when the cancer is very tiny, but that's rare. They might not travel when the cancer is big, but that's less rare. So that why we give the hormones or the radiation or the chemo is to try to decrease the chance of that cancer coming back around the body. So the simple question is, the risk of the cancer relapsing around the body where it's still breast cancer but might come back in brain, lungs, bone, liver, wherever, the risk of that is related to both the biology of the cancer as well as the stage. The third factor in that is the treatment. And across Canada, we've got pretty consistent guidelines. So most people across Canada are getting the best state-of-the-art treatment for what we know today, April 8th, 2021. And the tolerance of the chemo treatment is an issue. Some persons can't get through all the treatment, so their risk might be higher because they didn't get through all their treatment. But again, it's an individual thing, and it's a balance with their oncologist. What's the risk of getting cancer in the other breast? Lobular cancers have traditionally, people thought of them having a slightly higher risk. They have a slightly higher risk, but still most people don't get a cancer in the other breast. And there are way too many double mastectomies being done for the real risk. For most women with an infiltrating ductal cancer, so not a lobular, but an infiltrating ductal cancer, the risk of getting a new cancer in the other breast is about 0.5% per year. So let's say somebody's 60 and they're going to live to be 100. They've got 40 years. 0.5% per year is going to be a 20% risk. You then give them hormones, you decrease it by another half. It's about a 10% risk in 40 years. With lobular cancer, we think it's a bit higher. We think it's about a 0.75. So in 40 years, it might be a 30% risk. And then you cut it in half with the hormones, it's going to be a 15% risk. The other thing is that although mammograms, MRIs, or ultrasounds don't decrease the risk of getting the cancer, people getting regular follow-up imaging can detect a cancer very early, so they might not need to lose their breast even if they get another cancer. So I think the big thing is a lot of women over-exaggerate their risk of getting a cancer in the other breast, and their bigger risk is often the risk of the cancer that they've had coming back. 3 risks, just to remind people. So there's the risk of getting cancer in the other breast. There's the risk of getting cancer around the body, which we've talked about, advanced breast cancer or stage 4 cancer. And there's the risk of getting cancer back in the breast where they already had the cancer. And what we do there is we try to do good surgery and radiation to decrease that risk. And hormone therapy as well in an estrogen-positive cancer will decrease the risk of it coming back in the affected breast.
Excellent.
Along that same line, just around sort of follow-up care after, there was a question from, I'm just trying to get to it now, Carrie, I believe, but it was actually around looking at additional, can we be doing blood work? Is there additional testing in follow-up care other than going back to having just a mammogram done to determine whether or not the cancer has returned?
So that's a common question. Right now in 2021, there's no validated blood test to show. Years ago, people used to get annual chest x-rays, annual bone scans, annual this and that, and it was a lot of radiation that people didn't need and probably caused more cancers. The American Society of Clinical Oncology does not recommend routine blood work or anything other than history, physical examination on a regular basis, and annual imaging of the breast, because that's where you can pick things up early. A lot of people think, oh, I live in Canada and it's my healthcare and that's why I'm not getting blood tests and everything all the time. That's not the reason. The reason is that at this point of time, there's no benefit in doing it. Now that might change quickly, There's a lot of work going on around something called circulating tumor DNA, which you can find in the blood. At this point, it's not validated, but I'm hoping in the next decade or so it's not tomorrow, but in the next decade, we've got enough validation so that persons with breast cancer can be followed with circulating tumor DNA, which may diagnose cancer earlier. The next question is going to be, though, does it make a difference to diagnose it earlier? And I happen to believe it will, because our treatments might be more effective then, but those studies are going to need to be done to know whether it does. The other thing is the ethical principles. One of the ethical principles of being a doctor is beneficence and non-malevolence, so not doing harm. And what we don't want people to be is so tied to a blood test or so tied to the anxiety around a blood test. A lot of persons feel anxiety around their doctor's appointments or their tests, and you don't want to have that happen. You don't want to have people so tied around a blood test that they say, oh, April 1st, I got my blood test, it was fine. Even though I can't lie down on my back because I've got such pain, I'm fine because my blood test was fine. No test is perfect. What you want is, if you can't lie down on your back, if you've got new back pain, you want to go to the doctor and make sure there's nothing going on in your back. So you don't want people to be tied to one test. The second thing is that you don't want to be doing the test every week. So if they say, okay, we're going to be doing this test your PET scan every year. Well, then the next time you say, well, can I get it done at 6 months? And then can I get it done at 3 months? And can I get it done at 1 week? You don't want to be tied to a test. We all have to learn, as I said earlier, about dealing with uncertainty. So my hope is for everyone out there having had a diagnosis of cancer, that in the next decade, we do have validated tests that can be done to diagnose cancer earlier. But even with those tests, they're going to have to be used in the right context. Somebody who's got diabetes, they might check their sugars if they're on insulin 4 times a day. They don't check it every hour. You put it into the context. You have to put it into what's going to make a difference in terms of the disease.
Have a very quick follow-up to the blood tests. What is your thought on adding to the standard blood work, the ONC1, for patients' tumor markers?
So
for instance, markers, CA125, and so on and so on.
Common question. Tumor markers are only good in following metastatic disease. So if somebody's got bony recurrent disease and you have a tumor marker like a CA15-3 that's elevated, and you put somebody on a CDK4/6 inhibitor and also on hormones, and the tumor marker comes down, that's helpful because it doesn't put all the onus on the patient to say, oh, my pain's better or my pain's worse or what have you. So that can be helpful. They're not the be all and end all. How the patient's feeling is the most important, but they can be helpful. They can be helpful sometimes at the onset. So I had a woman I saw last week where I was worried she had recurrence. I did tumor markers. They were up, and I did a PET scan, and the tumor markers, the PET scan, her symptoms, putting it all together, I think she's got recurrent disease. So they can be helpful there. They should not be used as routine follow-up. And that is included in the American Society of Clinical Oncology. And there are some tumor markers that are actually dangerous, like CA19-9 can go up and down with different stomach upsets. And somebody might think, oh my God, I've got pancreas cancer. They don't. So I think they can be dangerous. There's no role, and CA15-3, CA19-9, CA125, CEA, they've all been around for 20, 30 years. They've not been proven to be good for follow-up, and they shouldn't be used in breast cancer. There are some cancers where they're helpful. So a CEA might be helpful for somebody who's had a resected colon cancer, but not in breast cancer.
Thank you.
So just speaking in the metastatic space, if someone has no evidence of disease for years, are they considered cured? Or will they always have?
So that's a good question.
Treatment.
I can count. So from the MD Anderson a number of years ago, there was a study done where they suggested that about 5% of their advanced breast cancers were cured, that the cancer never came back. That means that 95% do come back, and identifying those 5% are hard. In my practice, I know a group of patients who are cured. It's been a long time and their cancer hasn't come back. It's probably 5% or fewer. The cured cancers are generally things like triple negative, where they respond to the chemo and they don't come back. And one of the things we know about triple negative cancer is that triple negative cancer, 5 years isn't magic. It's not magic for all cancers, it's not magic for breast cancer. But triple negative cancers, if they haven't come back in the first 5 years around the body, it's unlikely they'll come back. Not never, but unlikely. I can think in my history only about 1 or 2 where I've seen it come back after 5 years. If it's a HER2 positive ER negative, it's unlikely it's going to come back after 5 years. Not impossible, but unlikely. With estrogen receptor positive cancers, both HER2 and non-HER2, they can come back 10, 20, 40 years later. So 5 years is no magic. With an estrogen receptor positive cancer, it's very hard to say you're cured because it still could come back, and I've seen it come back at 20 and 25 years. With a triple negative cancer, sometimes you can say, yeah, I think probably you are cured. I've been caught before, though. I have a patient who appeared with an ER positive to be stage 4 NED, been on letrozole for about a decade, seemed nothing happened. She went off of it. She came back 5 years later with some recurrence. So, I think it's very hard to tell somebody that they're cured. But there are a handful of patients that do get cured, I think, a handful.
Well, and there's another question here from Sue, speaking specifically about patients taking with HER2-positive metastatic breast cancer receiving Herceptin and what the long-term stability is for that. She's been on it for 12 years and has stable disease, and her oncologist was saying there's 10 to 15% of patients with metastatic HER2-positive breast cancer who don't progress on Herceptin. Is that?
Yeah, I would agree. So the standard dogma is to continue the Herceptin indefinitely. And I have a woman who's been on Herceptin since 1999. That's a long time. 4 weekly she's on. That's a long time she's been on Herceptin. And I have another few from the early 2000s. I have had some patients stop their Herceptin for various reasons. And not all of them have progressed. Some of them have relapsed, some of them haven't. I think what we don't have is the ability right now to identify that small group of people where you can stop it and it doesn't come back. I have had one woman who has been on it from 2000 until 2 years ago. She progressed. Now she's on other treatments, still doing well now. But I wouldn't have predicted 2 years ago she would have progressed. This is where circulating tumor DNA might come in helpful in the future, but we don't have the technology yet.
That's really helpful. There's just switching to a question around biosimilars, actually, which we haven't even addressed yet, but someone receiving the biosimilar Ogivri for trastuzumab instead of Herceptin. And should she expect the same outcomes as she would with the reference biologic?
I think she should. I think we've seen a few different toxicities. Sometimes people have had some more allergic reactions with some of the biosimilars and fewer with others. All of the studies of biosimilars to date have suggested they've got the same efficacy. So I think that's not a problem. And one of the things that's really important to realize is that Herceptin itself, because of its manufacturing an antibody, is a biosimilar. So no 2 batches of Herceptin are the same as another 2 batches. So all of these antibodies are already biosimilars.
It's a great point and helpful in offering that reassurance. So I think we'll try and get a couple more questions in, mindful that we have about 5 minutes left. Question from Donna around, do HER2 cancers, are they more resistant to endocrine therapy? There's also some questions around triple positive breast cancers and how endocrine therapy relates in that space. If you could speak to that quickly.
So triple positive cancers is just another word for estrogen positive, progesterone positive, HER2 positive. And about half of the HER2 positive cancers are endocrine positive as well. There used to be some data suggesting that they were more resistant to endocrine therapy, and that's not come out very well lately. When you give anti-HER2 therapy, it seems to overcome a lot of that endocrine resistance. So they don't seem to be as endocrine resistant as we used to think. What's interesting is there was analysis of the soft and text studies. Those were studies that were done looking at young women and looking at exemestane plus ovarian suppression or tamoxifen plus ovarian suppression versus tamoxifen. And it didn't show that the exemestane plus ovarian suppression was any better in the HER2 positives than tamoxifen plus ovarian suppression. So I think once you get targeting the HER2, it's like the HER2 is the major driver and the endocrine is the driver beside. And if you're doing a good job of targeting the HER2, then the endocrine acts, alongside of that. I think what's important, and a lot of women don't understand, is that the endocrine targeting is still important, though, even if the HER2 is the major driver. So a lot of people say, oh, I've done chemo and I've done Herceptin and I've done radiation, I've done surgery. Do I have to do this endocrine therapy as well? And the answer is yes, it is important. It decreases the chance of the cancer coming back around the body in the contralateral breast and in the affected breast, and it's important. So I think we don't totally understand the endocrine resistance. I think there's some conflicting data around it, but I think it suggests that you have to target the HER2 and the endocrine.
I think that's really helpful. Anything to add to that, Kathy, or?
No, that's pretty
one more.
clear. You're going to get one more? We're going to get one more in?
I think we have time for one more here, and it's actually back to reducing your risk of recurrence. Or Dr. Gelmon, if there's one that I see you looking at the screen, if there's one that you think is really critical to answer, but this is around vitamin D. So vitamin D and aspirin, and I'm sure this is a question you get quite frequently. Will those help reduce the risk of recurrence? Has that actually been proven?
So number one, aspirin, there's a big study going on in North America, and the Canadian Cancer Trials Group, Clinical Trials Group, is participating, looking at giving aspirin to women or not to see if that can decrease the risk. And they're looking at it in colon cancer and in breast cancer. So the answer right now is we don't know, but it's something of interest. The second thing is vitamin D is important for everyone, particularly people in Canada, particularly people who use sunscreen for your bones. You don't want to get rid of your cancer and have bad bones. Whether vitamin D has an effect on cancer is not clear. There's been lots of stuff around whether vitamin D has an effect on COVID. There's been stuff about whether vitamin D has an effect on MS. I think vitamin D is important. The good thing that I can tell you is you can, whereas calcium, you have to take little bits during the day to absorb it properly. You can take your vitamin D once a week, and that's an easy way to do it. But all of us in Canada as women should be getting 1,000 to 2,000 international units of vitamin D a day. And I don't know if it'll reduce the risk of cancer, but it might, but it certainly will reduce the risk of problems with your bones. So that plus exercise plus not smoking are all important for your bones, and particularly for women who are on endocrine therapy, or women who have an early menopause after chemo, or women who have an early menopause for other reasons. Particularly for those women, vitamin D is important.
I have a quick question around the aspirin study. Where is it at this point, and what do you expect to gain from that? And what would be the side effects with aspirin?
So, cheap drug, if it works, that's great.
Yeah.
So where are we at? I think we're fully enrolled in it, but I think it's still going on. And these studies in early cancer take years to get an effect, like I said, with the MA32. So we don't have any answers yet, but I think it's a worthwhile study. I have a number of patients on it, and could be a cheap fix if it helps. And I guess always the question is, will it help all ages? Will it help all different subtypes of breast cancer? We don't know.
And what's the dosage that you are looking at?
It's looking at it's a 100 milligrams, so it's not the 80 milligram that we usually think about. It's a different formulation, yeah.
Interesting. Okay. So we'll have to see how that reads out. Well, I think that concludes our time for this afternoon session. Thank you, everyone, for the excellent questions and for taking time out of your day to join us. And Kathy, thank you, and Dr. Gelmon for a very engaging and always very informative discussion. We will be sending out a short survey to everyone after this call and would welcome and appreciate your feedback. Thank you again to today's sponsors, our gold sponsor, Viatris, our silver sponsors, Pfizer Oncology and Roche, and our bronze sponsors, AstraZeneca, Knight Therapeutics, and Merck. And thank you for everyone for joining us. We look forward to connecting on our next Q&A session coming up later this month. Have a wonderful day.
Thank you, Jen. Thank you, Dr. Gelmon. Bye, everybody.
Thank you for your questions and your moderating. Thanks.
Take care.